Well, Jerry, there's been some news.
What's the news?
Well, I don't know if you heard this or not, Mr. Hormone
I hear
Guru,
things.
but PCOS is now PMOS.
Fine.
We were joking before we started recording about how we actually did a PCOS conversation recently, and I think it was the very next day that all of the news came down that, okay,
Was it the next day?
yeah. So
That's
tell us,
funny.
is it polyendocrine metabolic ovarian syndrome?
Yeah, well, I mean, okay, so let's back up a minute. We've called it PCOS, which is polycystic ovary syndrome,
Mm-hmm.
for decades. And when you hear that,
I think ovaries,
right,
cysts.
when you hear the term, you're like, well, okay, it's an ovary problem. Well, the deeper discussion to have is it's really more of a metabolic overlying issue mixed with maybe some genetics that affect the ovaries. But the general public would go, well, okay, so it means I have an ovary problem, so I need a medication, or I need a thing, or I need my ovaries removed. No, you got to fix the metabolic problems. Like
It's
to
leading
say,
to
right?
the
Well, to say that I'm going to like take the ovaries away by surgery or by medication and fix the underlying other problems is like saying, okay, I got like this leak in my car tire, and instead of patching the hole, I just keep putting air in. Like it's, or taking the batteries out of the smoke detector when it's going off and not putting out the fire, right? I mean, like you're just covering it up. That's what I'm saying.
Yeah. When did we being you guys in the scientific medical
The
community,
nerd world.
the nerd world, I wasn't going to say it, but you said it. When did you start realizing that this was more of a metabolic problem?
I'll be honest about this. So when I came out of school, like what, 15, 16 years ago, I was trained traditional Western style of thought of this is an ovary problem. This is PCOS. I had a very cursory, superficial understanding of it, and I would have said at the time that it's like birth control plus or minus weight loss plus or minus a hysterectomy. That's how I would look at it.
Mm.
And now, and not even consider the genetic environmental stuff at that moment. And now, years later, going, wow, what a silly approach to that I had in my own head.
Mm-hmm.
And I bet you, if there's providers, mid levels, or even physician level people watching this, they're in a similar space if they've never really put the effort in to learn about it. And it's not their fault. Like, I want to say that up front. I'm not dogging on the providers out there that go, I thought it was an ovary problem. Like, it's okay, because that's how we've taught you.
It was
Right?
kind of in the title.
um, it is so much deeper than that, and so much more interesting than that, as to how this snowballs out of control for these people. And probably not in the context of this recording could we go into all the nuances, but I'll just say genetics in this are huge.
Yeah,
And
you mentioned genetics and environment. So talk about epigenetics. I know we're backing way up, but this to me is the most fascinating and novel aspect of PMOS.
Well, first
that
of all,
I don't think a lot of people are aware of. So can you break down?
100%. Yeah. Well, first of all, what does epigenetics mean? That's a term that's in the last 10 years has become a thing. Really, epigenetics, the idea of it really didn't become popular until the late 80s. Mm-hmm. And you had this guy from England doing research on beetles to say that epigenetics were a thing.
To most lay people, I'll tell you, it's a cool word. So why don't you
break
a cool
down word. It's a cool guy word.
Epigenetics. Right?
It's in every podcast forever now. Epigenetics. Think of your genetics as the library. So the books in the library have all the knowledge. So your genetics are in you.
It's the code.
It's the code.
It is what it is.
But if you were the user of the library and the librarian said, hey, you can't have this book today, you wouldn't have the knowledge out of that one book that day, right? Epigenetics is the librarian. It is the gatekeeper that's influenced by outside sources like your environment that says you do or don't have this trait at this moment expressed.
Okay? And how your genes express themselves.
Right. And now we know there are clusters of genes that work together like Christmas tree lights, so to speak. You ever seen those drone formations that make pictures in the sky?
No, this sounds like a you thing.
You haven't seen that? I gotta show you stuff after this.
Are we talking chemtrails now?
Oh my god, aluminum and chemtrails. No. So
sure, I've seen those.
So depending on what color the lights are, the picture changes, right? Mm. So just like that in real life, the joke is, the genetics for you loads your gun, but the environment pulls the trigger for you. So let's say every member in your family is a diabetic. Every member. but you've kept your body weight low, you eat super clean, you exercise every day, you get the sleep, you get the hydration, you keep the stress off, and you are not technically diabetic at that moment,
Sure.
right? But then all of a sudden something happens to you and you gain some weight and you quit exercising, and now the genetics come into play and now you're diabetic.
So in the
Right.
same way, for example, that you can have everybody in your family is addicts, but there's no addiction gene. What if, why, can you get back to explaining like why does PMOS run in families?
Oh, heavily. The literature kind of suggests here that if you had a first degree, like your mother or your grandmother had PCOS or PMOS, whichever one we're going to call it today. I like PMOS now. Let's just stick with
Let's
that
roll
from
with
now on.
that.
Yeah,
Yeah.
PMOS. If they had it, they have about a 2 to 3 fold risk of passing that on to you, or you have a 2 to 3 fold risk of having it. Now, let's say they had the genes, but they weren't themselves PMOS. You still have a rate of passing it on. It's just not the same rate, right? So the environment of the fetal development influences how the brain of that fetus develops, how the hypothalamic tract is developed. And interestingly, if your grandmother or great grandmother wasn't necessarily PCOS herself, but had some of the genes, and at the moment of pregnancy had high testosterone or high insulin levels, your mother started to develop, and you were inside your mother at her development. So you were in this environment, you as an egg, right? And your hypothalamic tract may develop more male-like as a female,
Mm-hmm.
and have higher testosterone values, more insulin resistance values. It's very interesting how the fetal environment set up the genetics to be passed on.
And when you talk about the fetal environment, really androgen,
for the most part, but insulin as well.
insulin as well.
Yeah.
Okay.
So hyperinsulinemia,
Which is metabolic.
Because this is metabolic,
okay.
and high androgens, either both or singleton, can precipitate these changes that we know downstream. It's fascinating.
So how would you, a couple of questions then for a woman with the signs, symptoms, party foul, for a woman with the signs and symptoms of PMOS, let's say she's been diagnosed for the purpose of this exercise, how would you, when it comes to fertility, because I know a lot of women with PMOS who are trying to get pregnant, how would you treat her or advise her leading up to what would be the, in a perfect world, if you had all the time in the world to prepare?
Well, I mean, one of the big problems with PMOS is as the regulatory system of the brain, the hypothalamic tract, talks to the ovaries and the adrenal glands, and you're trying to have a consistent cycle and a consistent ovulation, and then capture a fertilized egg in the lining of the endometrium here, or the uterine lining. Sorry. To better raise the chances of that happening, you have to have a predictable ovulation, right? So step one, how do we do that? Well, get your insulin burden lower, get your blood sugar down, fix your sleep-wake cycles, get your cortisol down if it's elevated because you're all stressed out and angry. And as the insulin goes down, the luteinizing hormone burden becomes less and has a more cyclic pattern, as it should, rather than being constantly elevated, which lets the egg mature the way it's supposed to as it's selected out of the ovary. Because in times of high luteinizing hormone and low follicle stimulating hormone, sorry, we're getting really nerdy here. I didn't know we were going to get into this. If the egg never matures the corpus luteum to an extent, you don't really have the progesterone to keep the lining to hold the egg. It's progestational, right?
Yeah.
So it's kind of a multi-armed approach of how do we fix this? Well, step one, get your insulin under control, address the progesterone deficit if there is one, and try to reduce stress and have a healthy, lifestyle. So what does that mean? Well, sleep, eat, exercise, all the things. I know it sounds mundane and like everybody says that's the thing. It truly plays a role in these women. It is a thing for sure.
And the trick is to do that without adding a self-care to-do list and another stressor to your plate.
Sure.
All the apps and
there's
classes.
Right. And there's some simple things on top of that you could do. I mean, simply vitamin D and inositol have been shown more normalize the menstrual cycle and lessen the luteinizing hormone burden. So in a lot of PMOS talks that I have with women, and I'm not necessarily just jumping straight to medication if I can, I want to do something to get their insulin down. So maybe like eat less carbohydrates and exercise.
Mm-hmm. You can start there.
Sometimes berberine is a supplement.
Talk about inositol and berberine.
Yeah, sure.
How they do that.
Well, I mean, berberine is kind of like a similar action as metformin. It lowers insulin resistance as a whole, and inositol as well, which we used to think is one of the B vitamin families. It's not technically a B vitamin family anymore. It also has an arm in not only lowering insulin resistance, but helping to propagate how the ovaries process hormones. In fact, some of the high testosterone values that happen in these PMOS women can be offset by taking an appropriate amount of inositol. That's a fascinating part that no one really talks about.
That is fascinating.
Yeah.
What about PMOS? Is there a male version?
I think there maybe is.
You think so?
I say it tongue in cheek because obviously males don't have ovaries. I do think that there are genetic traits that are similar and make these men more prone to insulin resistance via their genetics, and functionally keep their hypothalamic tract aberrant of the typical male. You may see testosterone fluctuation in them as well, or estradiol. The testosterone ratios fluctuate. I do think there is some genetic cousin of PMOS in males. Yes, yeah. I do believe that.
Do you see, back to the women, do you see a lot of anxiety, depression?
Oh my gosh. Several big published studies, a couple European ones, one here onshore. There's like a threefold rate. So I think the number was 1 in 3 women with PMOS have anxiety/depression. That's a huge number to me. Wow. It's a huge number. So, yeah. Crazy. And I think I personally, but I think the medical we have done a poor job of understanding that this is not just one diagnosis. This is a syndrome of things, and having PMOS or PCOS pulls in these other things that aren't necessarily just separate. You got to look at this as a syndrome and treat all of this, not just, hey, here's a depression pill and that fixes the depression, and hey, here's birth control for the bleeding. Like, it doesn't work that way. Mm-hmm. That's not fixing the problem. That is covering the problem up.
Yeah, playing whack-a-mole with the symptoms.
100%. Yeah. 100%.
So where would you start then with? I hear personally from a lot of friends, they go straight to, well, PMOS, I'm going to go on a cycle of a GLP.
Mm-hmm. Well, okay. So we're jumping straight to a drug. Okay. The GLP is an excellent choice for the insulin resistance for sure. Mm-hmm. And I do think that is probably the mainstay for a lot of women that I encounter. But we're assuming that they don't need progesterone, or they don't need all the other lifestyle choices, and they don't need vitamin D and inositol. So just like, here's a GLP that will get their insulin burden down for sure. That's not the only avenue. It's not the only one. It's a big start, sure. But I would think that for the cost and for some of the side effects, I would rather start with berberine or metformin, as they're pretty proven, but maybe that's not tolerable. You know, sometimes metformin and berberine have GI side effects that people don't like, or perhaps it's just not powerful enough because they didn't take enough lifestyle steps, and now I need to step it up to a GLP. Okay, fair. But I do think something to lower insulin resistance is part of the equation.
Do you have any success stories you can think of off the top of your head?
We treat a lot of PCOS through our clinics, a lot of PMOS. Sorry, I'm still learning to call it PMOS.
We'll get there. PMOS.
Sorry,
PMOS.
America. But I can't tell you. I mean, it's in the hundreds, if not thousands, of PCOS women that I've been involved with that either wanted to get pregnant and couldn't, and now they can or have, or perhaps it's just changed their cycles to the point where they go, hey, you know what? I don't now become anemic because I bleed so heavy, and you know what? All the pain that I was having with sex is gone, or my body weight's now acceptable to me, and I'm not depressed anymore or have anxiety about social settings or whatever. So yeah, I mean, I don't know of one off the top of my head because they're so numerous. I would just say, if you're a patient and you're struggling with your bleeding cycle, you're struggling with your body weight, you're struggling with the mental parts of those things, you're struggling with painful sex, you're struggling with getting pregnant or having a fertility issue, it's time to go somewhere where you have a conversation of this manner that's not just a simple here's birth control or go to a fertility clinic and get IVF or whatever.
Or remove your ovaries.
Or just have a hysterectomy in general. I mean, sometimes that's necessary.
Sure.
Clearly, but not every time. And I think we've overdone that. And the classic traditional treatment for some of these complaints we're talking about, if you looked at like the ACOG guidelines, the gynecological guidelines would be like, here's birth control and here's Neurontin and here's a depression pill. Literally, that's in the guideline. I would prefer to avoid all three of those things, period, forever. Never use those.
Do we know an estimated underdiagnosis rate of?
It's estimated that somewhere around 60% of PMOS goes undiagnosed.
Why?
60%. Well, I mean, access to care, the knowledge of the provider they see, perhaps not meeting all the Rotterdam criteria, the diagnostic criteria, because that criteria is somewhat exclusive when you look at how we in America diagnose true PMOS for insurance reasons versus how the rest of the world with the international guidelines do it. Our guidelines are somewhat exclusive, although they're changing. I'm getting updated. Thankfully, thank you. I think there's just, it's multifactorial as to why, but I bet you the number one is a female patient says, well, I'm just fat.
Yeah.
It's, I don't know anything else other than I'm just going to quit eating. And let me just tell you, there's several subtypes of PMOS we haven't talked about. There's the obesity driven primarily, or the genetic driven primarily, and then there's the adrenal driven version. Taking the adrenal driven version and telling them to go like on a massive calorie deficit and do like HIIT, high intensity interval training, actually makes them worse.
Yeah,
it's the opposite of what to do. So you have to ascertain, like, who are you in the context of your version of PMOS? What treatments can you accommodate, like afford, are willing to do, your lifestyle changes, and then have a provider that's willing to work with like your bio individual needs. You know what I'm saying? Like, this is not one size fits all. This is not, we're snowflakes, whether you want to admit it or not. And every case has a nuance. I say that all the time. It just can't be a one size fits all. I wish it could.
Yeah, even
my life would be way easier.
Different versions of PMOS.
Oh my gosh. Yeah, I consider the traditional versions, which you'd have of like, the overweight, insulin resistant person. That's the easy one to spot. But then you get into the adrenal version, like I said, or maybe more near and dear to my heart because I'm a nerd, the luteal phase defectors, that inside the luteal phase, they either don't make enough progesterone or they have just inherent receptor resistance to progesterone. And they look sometimes mostly normal on the outward. They're not necessarily obese. They just have a progesterone deficit. Well, guess what? That's a form of PMOS. So you need to go to a provider that understands those things.
Sounds like you're pretty fascinated with this topic.
This is one of my most favorite things to deal with in clinic.
We'll have to do more of these then.
I love it.
Thanks, Jerry.
Thanks, America.